welcome you back to our platform. Um, Last video I discussed how students choose their learning objective and placement. Today I'll be talking about mental diagnosis. It's one of the important module in nursing training, and you might have been taught in the uni about some mental diagnosis. You might have seen it in placement if you've been in placement before, and if you are going for the first time, if you've done like a support worker before, you might have heard about some diagnosis like paranoid schizophrenia, AUPD, schizoaffective disorder, delusional disorder, and depressive disorder. All these diagnoses you might have heard about there. Well, we'll be talking in more depth about them, and we'll be talking about why people have to have diagnosis, and why do you have to have diagnostic tools to diagnose people. So we'll be talking about all that. But before I move into that, I would like to create kind of background for you so that I can help you to understand, because we're talking about some of the symptoms and signs of psychosis. It's based on the symptoms and signs of psychosis that all these diagnoses are based on, because they try to classify or categorize people based on and based on their signs of symptoms. That's how they try to categorize people, and that makes them to form a diagnosis. So it is important that you understand what they talk about symptoms and understand what are signs before we move to the talking about diagnosis of various diagnoses in mental health. It's just simply defined as disorder of mind, and we'll be looking at emotional state. When we talk about emotional state of mind or emotional state of someone, we can use two terms to describe emotional state. We can use the mood. What is the mood of that person? We can use the affect. What is the affect of that person? Mood is the internal manifestation of how people feel. You cannot see it outside. People cannot know what is actually in yourself. Unless you speak to them, unless you talk to them, they will not be able to know what you are feeling inside yourself. So that's why the mood is internal manifestation of your feeling. If I'm happy, if I don't show it in my face, you will not know that I'm happy. If I'm sad, if I don't show it in my face, you will not know that I'm sad. So it is internal as a mood, internal manifestation of how I'm feeling. But my affect tells you a lot about my mood. My affect tells you a lot about my mood. If you see someone that is not, if I frown my face, you don't ask me what is wrong, because you think my face is not actually welcoming. So that is affect. You can see it. Affect is the external manifestation of your feeling. External manifestation of your feeling. It's something that sets you out. It's something that tells other people what something's going on with you. So there's a difference between affect. So students should actually take cognizance of that. You need to understand that the mood and affect are two different things, but they are still talking about emotional state of mind. So mood is the internal manifestation of how someone is feeling. Affect is the external manifestation of how someone is feeling. So there are two things, but one you can see, the other you cannot see until that happens to you. But mood can actually be altered. What I mean by your mood can be altered in that it can be anxious, you can be low, you can be irritable, and you can be hungry. So that is the nature in which your mood can be altered. Someone that is anxious, probably you see something that actually frightens you or something that you're worried about, you can get anxious, and it can manifest in kind of your physical presentation. You can be sweating, you can be restless. So that means you are anxious. That's your mood. You're anxious. You're low in mood. You can be low in mood when you um, feel down. Probably you hear about bad news. Probably someone the kind of like the circumstance you are struggling, and it's not really bright for you. So you can be low in mood. You can be elated, like a bright mood, high in state of a mind. Probably you won a lottery. You can be elated, jumping up and so you can be elated. You can be irritated. Probably you don't like the environment you are. Probably you don't like people around you. You can be kind of irritable. You can be hungry. So if someone done something to you that you don't like, you can get hungry. So that's how your mood can be altered. And your mood can fluctuate as well. The fluctuation is that it can go from low to high. It can go from kind of high to low, can be moderate. So your mood can fluctuate as well. So when that this we term this variation of your mood in terms of fluctuation, we term it in terms of the way we see it. Each variation is if your mood varies so quickly, it's an increase, variation increase. We can say kind of like you label in your mood. You label in your mood. Ability that you label in your mood. But when it's just extreme variation, you can say that you have emotional inconsistency, kind of emotional inconsistent, your extreme variation in your mood. But when your mood kind of variation is reduced, kind of reduction in variation of your mood, you're not showing something to actually kind of make people to see you are kind of bubbly. So you can say your mood is blunt. You're not showing any feeling. You're not showing any feeling. Your mood is blunt. Or we can say we can use flatten. Your mood is flattening. So all these terms is used to describe the emotional state. So when you're doing assessment at times, this is how you describe what you see. So symptoms, we discuss symptoms is a description of what people say is happening to them. Sign is what you can see. So people you I'm happy today, and if they say they're happy, you can see it in their affect. That means it's showing the same thing. When the affect and the mood is not saying the same thing, that is what we call incongruous. That your affect is saying something different to your mood. That's what we call mood incongruous. So when there's a mood incongruous, there's a suspicion that that person may be presenting with psychosis. I'll give you an example. When somebody's won a lottery, normally we expect that person to be jumping up and down, happy, showing some of brightness, but it just comes sad. It just comes withdrawn, not celebrating. You can be looking at the circumstance this person is not in congruence with the mood, that the affect that is coming out. The affect is not agreeing with the mood. That is mood incongruent. Like you give somebody news that you just lost your mom and started laughing, jumping up and down. That is, the affect is not in congruence with the mood. On a normal day, we expect that sad. But you just told the person about the news of loss of their loved one and they started jumping up. That's the mood is not agreeing with the affect is not in agreement with the mood. That is what we call mood incongruence. You're going to see this kind of feature in people with psychosis, that come with psychosis. So that is part of symptoms of psychosis. So your symptoms is description of what people say is happening to them, and sign is what you can see. So, and this is what is put by the psychiatrists to arrange people, to classify patient into different diagnosis, to classify them into different form of diagnosis, so that they can have, the people can see it in the same way. Like if a psychiatrist put someone in one particular, and they go somewhere else, they still gonna have the same diagnosis based on, because they diagnose it based on the presentation of the description of their symptoms and the signs they're presenting with. So we'll be looking at, or we've looked at emotional state of mind. We're going to be looking at symptoms of psychosis. I've already told you psychosis is kind of a disorder of mind, but psychosis can come in two phases. The cause of psychosis can either be organic or functional. When someone actually have a psychosis that's originated from physical or biological factor, say the psychosis is kind of from organic source. But when someone have a based on functional level, like emotional imbalance, emotional disturbance, that's functional psychosis. So there are two types of, note of that, two types of psychosis: organic cause of psychosis and functional cause of. Organic cause of psychosis is caused based on physical or biological factor. When I mean physical or biological factor, have a physical health problem that can manifest in terms of psychosis. Someone that have the delirium can come with some hallucination, seeing things when nothing is there, psychosis, or someone that come with the withdrawal of alcohol can start seeing something, can start coming with symptoms of psychosis. So that is organic cause. Organic cause, or some infection can make people to have to present to have some sign of psychosis. So that is organic cause. That's psychological, organic cause or biological cause of psychosis. But when it's like emotional disturbance, probably someone just go into depression based on the fact that there's a series of bereavement in the family, or sort of other reason that are kind of emotional attached, and that person plunges into psychosis. That's emotional cause of psychosis. So that's that. We're gonna be moving to another symptoms of psychosis, which is referred to, people talk about hallucination. What is hallucination? Hallucination is about sensing something that is not there. Hallucination is about sensing something that is not there. So we have how many? We have five senses. We have sense auditory, we have vision, we have olfactory, we have smell, and we have touch. So these five senses is the way we can be affected by the hallucination when people are in psychosis. So hallucination is about sensing something that is not there. So you need to understand this, because you're going to come across it in your placement. So hallucination, I'm going to say this, I'm putting this to you in a very lay man that you're going to understand it. It's about sensing something that is not there, and it affects, because we have five senses. We have auditory, we have vision, we have olfactory, we have taste. That's a taste. We have so when someone have auditory hallucination, they will talk about his. They will talk about the voices can be in any form. It can be first person, it can be third person, it can be any form. But the point there is that that person is talking about hearing voices when other people cannot hear what he's hearing. That is auditory hallucination. That hallucination affects the auditory sense of that hallucination. So when they do classification of diagnosis, they're talking about the the description. Description is that the person is hearing voices. So the content is what the person is hearing. So there are two things: the hearing voices and what is that person hearing is the content. So diagnosis of a patient is based on the description of what is happening, which is the uh, hearing voices, the description of the what the person is having, but the content of it is what the person is hearing. So auditory hallucination is about hearing voices. The voices can be saying something derogatory. Something the voices can be talking in having conversation, or the voices can be in terms of a third person. But there's what we call pseudo hallucination. Pseudo hallucination is hallucination that is not a real hallucination, that is actually coming form of hallucination. When someone said, "Oh, I'm hearing voices," it's always important when you are doing your assessment to ask whether the voices is coming from that person's head or it's coming from outside the head. When it's coming from inside the head, it's called pseudo auditory hallucination, because the voice that's coming from head is actually your thought that is coming from the four voices. But when the voice come outside your head, that is when you actually is responding to external stimuli. That is the voice. That is auditory hallucination, which is not a pseudo hallucination. So you need to differentiate between pseudo hallucination and real hallucination. So auditory hallucination is about people hearing voices, but it not depends on what they are hearing. It all depends on whether the auditory is first person, third person, or kind of like people having conversation. So that is the content of that hallucination. Hallucination can also be in form of visual hallucination, when people are seeing something that is not there. That kind of hallucination affects the vision, sensing something that's not there. Remember, hallucination sensing something that's not there. So that affects the sense, vision sense. That sense of vision. That's one effect. That's hallucination that affect the vision, the sense of vision. That's visual hallucination. They see something that other people cannot see. That is that's hallucination. So what we call about smelling something that is not there. Someone can say, "Oh, I can smell gas. I can smell this," when there's no actually apparent of any gas smelling. That is what we call olfactory hallucination. Olfactory hallucination, smelling something that other people cannot smell, and it actually affects your sense of smell. Hallucination. But when we talk about taste, some people put the honey in their mouth and say it is bitter. In the face of every evidence that it is not bitter, other people taste it's sweet. So that is sense of taste. We call it gustatory hallucination. Gustatory hallucination. You can also have hallucination in your placement. We'll talk about touching. When somebody say, "Oh, something is crawling in my body, somebody is touching me," that is tactile hallucination. Tactile hallucination. That's hallucination that affects the sense of touch. Tactile hallucination. So we have 5 types of because affect our 5 sensory organs. So 5 types of hallucination. That's that. So we move into delusional idea. People have a fixed idea, fixed belief about something, fixed that you cannot really change with argument. It is what they believe. It is fixed. You cannot change it. Even arguing with them is going to actually make it worse, because that is what they are experiencing. It is real for them. So you have a delusional idea. You cannot win by arguing with them, but you can only challenge it gently, and you have to be to a certain stage of discussion because you can start challenging. If you collaborate with them, you are in a situation where, because you actually making it worse for them when you are kind of validating, oh, when somebody say, or I believe everybody's out, everybody doesn't like me, and you're saying, yeah, that's how it is. You are validating it, you are making it worse for them. So the delusion that fixed belief about something that it's very difficult to change. You cannot actually change it. You cannot argue it. You cannot change by argument. That's so we have different form of delusion. We have delusion of guilt. When people guilt about something, probably it's not really their fault, but they think they it is their response. Like if somebody like probably someone some a child by accident, and it has the guilt that the child, I didn't protect it, I didn't do much to protect. So they lost their brother by accident. They also, I didn't protect that person there enough. So they have that fixed delusion of guilt. And they may have the delusion of guilt as worthlessness. They may feel they're worthless as them. So these are kind of a delusion that you can see in the kind of people can present with when you hang your placement. Delusion of reference. Delusion of reference comes in form of when people are attaching themselves to something that's actually not really connected to them. You can probably somebody's watching a TV and they say, "Oh, it's me they're talking about. It's the news is about me. They just know that I've done this. They're talking about." So delusion of reference is connecting something that actually had nothing to do with him or herself. That is delusion of reference, making that as a reference to himself, but it has no connection to that situation. That's delusion of reference. You have delusion of persecutory delusion. Persecutory delusion is when people think people are after their life, probably because they have information that is important to those people. People can come out and say, "Oh, the MFI is after me because I have the information about something that can actually affect the whole world." Or people think I have a secret. They'll say, "I have a secret that people are looking for," so they after my life. They are actually watching over me, trying to monitor my movement because they think I have something that they may of important to them. It's like persecutory delusion. People are thinking that people have to their life based on the value of things they have. That's persecutory delusional idea. Now, delusional idea, people can be paranoid. Probably they think people are doing something to them, or they just too suspicious of people. They're just too suspicious of. They will think, oh, people are putting poison in their food, or poison in their water, or they think the neighbor is actually watching over them, or they think when they go out, everybody's watching them. So that's the delusional paranoia idea. It's actually one of the delusional idea that you can see presenting with patient present with when you're in placement. Nihilistic delusional idea. It is nihilistic delusional idea is people think what is going to end, or they think something going to come to an end, and they're preparing for it. They're telling you that something is going to actually something's going to happen, something bad is going to happen, and they're preparing for it, and they it's going to be so serious that it's because it's real to them. They're going to make you believe that this is what is going to happen. Tomorrow, or something bad is gonna. That's anistic form of delusion presenting people with psychosis. We have hypochondrial delusion. Hypochondrial delusion is when people think when they are fixed with the belief that they have physical health problem, even in the face of evidence that they have a physical health problem, they have been checked by a doctor, there's tests been done, but they still not. They don't have that physical health problem. That's the hypochondrial delusional idea. We have religious delusional. We have to be very careful when we're trying to actually place these people under this psychosis presentation or symptoms, because we need to look into caution background. When I talk about delusion of religion, um, we need to be very careful not to stigmatize people or not to present present people in this form, because people come from different cultural background, different religious belief. I'll give examples. Some religious believe they can hear the voice of God, they can hear God talk to them, but you will know it when it's become a psychotic presentation. But you still have to have at the back of your mind that people do have some fixed delusional idea that is actually known to their society. But when it is out of known to the society, then you start to look at it as one of the traditional idea people believe. When they talk like placing it in terms of people talk about delusion, religion, something's gonna happen now. They just focus on that, and they make it as something that is actually real for everyone. That is what called delusion of religion. Delusion of jealous. That's a delusion of jealous. This is more kind of more happening with men when they kind of over suspicious of their partner, or thinking that the partner is actually kind of cheating on them, or they think their partner is, they are just too suspicious of their partner. It do happen in men, in women as well, but it's more likely more of men. So you have that kind of delusion when with patient with psychosis. And another one is the grandeur delusion. Grandeur delusion is overvalue idea, when people think they have something that they don't have, in terms of like placing themselves so high than what they have. Someone will say, I'm a member of royal family. Someone will say, I'm close to the royal family. Someone will say, I have a lot of money in the bank account, where he doesn't have anything. So this is kind of odd. Someone will say, oh, I'm close to the American president, or I'm close to one celebrity. Or no. This is kind of overvalue idea that come in terms of psychosis presentation as a delusion of grandeur delusional idea. And we have a delusion of control. Some people also present with delusion of control when people think some people are actually design and control their life. So where in the evidence in the face of everything that is not happening, but this kind of a presentation, you can see that in you can see that happening in people with psychosis, as that's a part of description of their presentation. So that is also delusional idea that you may see during your placement. So all this that I've talked about is some of the things that you may see when people are presenting with psychosis. That some of the things that may come as symptoms and the signs that you may see in people with psychosis, and they play a role in how they categorize them into what diagnosis they give to them. So let's talk about, why do you have to categorize people? Why do you really have diagnostic tools for categorizing people? When the mental health people were just started to know mental health in terms of dealing with mental health, it's come to idea that we need to come with the tools that we use, so that we have a unifying and agreed way of categorizing mental health problem, so that we have the same way of classifying people into different categories based on how the symptoms they present with, in terms of based on the signs they present with as well. So that when someone is diagnosed here in the UK, and when they go to America, they still have the same diagnosis, because they have of a category. Somebody that's diagnosed here, if he gets to Nigeria, still gonna have the same. If it goes to any other part of European country, it's gonna have the same diagnosis. Go to any Asian around the world, it's gonna have the same. All over the world, gonna have the same diagnosis. So that is the reason why they come up with these diagnosis tools to have agree way of arranging people based on the symptoms they present with. The first one that they use, the one they use mostly in the UK, in European countries, is approved by the World Health Organization. It's called International Classification of Disease, 10th revision, clinical modification. It's called ICD-10. ICD-10. You see doctors coming out with those put in the front of each of the that is the diagnosis to ICD-10 CD. That's what they use in here in UK and part of the Europe. But another one that they still use is called Diagnostic Manual of Mental Disorder. It's called DSM edition 4 now. So DSM-4. That is the one they use mostly. But they all have the same similar grouping people into a particular diagnosis. So why do we classify, or why do you categorize people into diagnosis? The first thing is to help people to have the right treatment. If people are not given the right diagnosis, they will not have the right treatment, and the expected outcome will not be achieved. So why people are given the diagnosis is for them to have the right treatment and to have expected outcome. So if someone is being put on the wrong diagnosis, then it's going to be wrong treatment. So that's why it's important that people are placed in the right diagnosis. So if you get to your placement, you'll see different category of patient with different diagnoses. Sorry, their presentation, the description of their symptoms and is what they use to put them in different diagnoses, using these diagnostics tools that have just two diagnostic tools that I've mentioned. So if you look at this, if you look at the when they put the diagnosis, you see number in front of that diagnosis. That is the number of ICD-10, or if they use a DSM-4, it's going to see that number there. But mostly we don't use DSM-4 in UK. We use ICD in UK. So you see the number there. That's the number of the diagnostic tool they use, and it comes with different mental health diagnoses have different ICD numbers. So you take it when you get to your placement area. So that is why that's one of the reasons why they categorize people into diagnosis. Another thing is to actually give room for research, so that you're going to have unifying way of to help research across the world, so that we have the way of describing the symptoms in the same way that the way they describe symptoms here is what the way they categorize symptoms in America and other parts of the world. That is important of having a diagnosis, to have right treatment and better and expected. It's help with research, and it's kind of a help in it also help in collaboration work from one psychiatrist to another psychiatrist as well. So that is important of putting people in the diagnosis category. So we'll be talking about each of the diagnoses in my next video, because I don't want to be too long. And what I've done today, I'm going to actually bring a kind of brief discussion about before we go further on the talking about the different of diagnoses that we're going to come across in your placement. We will talk about each of them. I'm going to use the layman term so that you understand it. I'm not going to use most of the jargons that will be kind of make it difficult for you to understand. But I'll use simple language to explain those diagnoses to you, so that you can have better understanding of it. So that next video is going to cover that. actually know that this none of these things, some of these things will be taught in the school, but you may not have enough time to explain all these things to you. That's why I'm taking it kind of as something that I need to do to help students to kind of have a good understanding of this. It's going to be useful for you, and it's part of what is going to help you to be a nurse, a good mentored nurse. So if you watch this for the first time, this video is always done to support semi-bed care, domiciliary care company. We provide their care that have loved ones that need carers. So if you are watching and you have a loved one that you need a carer for, you can contact us. Just put it in. I'm going to get back to you. And if you have any comment about what to this section today, put in the comment. I will address it in my next video. So thank you for watching. I'll see you in the next video.